All right, everybody, welcome back for another episode of the Barbell Therapy Podcast. I am your host, Dr. Brett Scott, and with me here today is probably our biggest guest to date, Dr. Rand McClain, and he's been featured all over the place. So he's been on one of my favorite podcasts, Mind Pump Radio. He's been featured on ESPN. He's been on a bunch of radio shows, in the newspapers, on Yahoo News. He is a doctor of osteopathy, and he owns Regenerative and Sports Medicine in Santa Monica, California. And he's here today to talk with us all about hormone replacement therapy, maybe a little bit about peptides and longevity and sustaining a healthy long-term life. So, Dr. Rand, thanks for coming on today. It's a pleasure to have you, and super excited to have you here.
My pleasure to
So,
be here. Thank you.
yeah, no problem. I got super excited. He commented on one of my podcasts, and I couldn't help but ask to have him on the show. So we're excited to have him here today. So as far as this goes, there's a lot of different things you do in your practice now. But how did you get into this field of regenerative and sports medicine? Because he's had quite the track record of all kinds of different career paths, including being a CPA, a national level water polo player. He's a reserve sergeant on a police academy. So how did you end up here?
Well, I have to give credit to my parents. I grew up very lucky to have two parents that cared about their kids, and we had a library growing up with encyclopedias. And my mom was really into nutrition. We used to get served wheat germ pancakes, which were terrible at the time. We felt like we were getting the big jip. But in hindsight, I mean, my mom obviously really cared about our health, and it really clued me into nutrition. And Adele Davis was one of the books on the shelf. And I remember, I think I was about 11 years old. And I think I was actually sick and looking for things to do. So I went into their library and pulled it off the shelf and started reading about how nutrition could affect your health. Sorry for the long-winded answer, but that really, I think, set everything in motion for me. So throughout my so-called athletic career, if you want to call it that, I depended upon nutrition a lot. I tried it all, from the rocky eggs in a glass when that appeared, to the liquid proteins, if you remember those, probably well before your time. And I had to cut weight for a lot of things as a wrestler and a fighter. So got into nutrition, and then I shouldn't say I lost any interest in it at all. I really, for lack of, call it motivation or for fear, I just figured, well, gosh, doctor, and that's kind of a hard thing to do. And I was having so much fun in school and in sport that I followed in dad's footsteps to be an accountant. So I did that out of school, and then, it just wasn't for me. And then honestly, smash cut to a lot of years later, I was getting ready to have my first child. And I thought, okay, dude, you gotta settle into something, and it ain't what you're doing right now. I was doing it was my eighth career at the time. Don't remember, like an internet company or something. And I said, what do you really want to do? I said, I want to be a doctor. If I'm going to settle into something, I've always loved this. And so that's a short story long there for you. That's how I got into medicine. And then how did I get in this particular field? It really is, and we were talking about it earlier, there's no such thing as a regenerative medicine specialty, right? But I've always been involved in sport. I've had so many injuries, and including surgeries and procedures. And so I learned a lot because of what I went through. And this is my passion, as they say, but it really is. I mean it. I'm going to beat I read in the paper there was a guy who's practicing at 99, and I hope to beat his record. I love this stuff, and it just it just seemed natural, and I'm glad I made the choice, and that's where I am today. Just again, a short story long.
And was there anything you've kind of seen wrong with how, or something missing from the traditional medical model of, someone comes in with symptoms and we put Band-Aids on it, or there's a better
Yeah,
way?
that's a whole other podcast, as you probably can imagine. I mean, the short of it is, yeah, I mean, that's how I got into Chinese medicine actually before I got into this kind of medicine, because I was very frustrated with Western medicine. Not just the lack of efficacy that I saw for a lot of the things. I mean, for example, when I first broke my neck, the only option was what essentially amounted to a door hinge in my neck, or to fuse it. I'm like, man, I'm 20 something years old. I'm not doing that. And I felt like There should have been more. So I was looking outside of Western medicine, sure. But I think the biggest problem I have with it now is it's been monetized so much. And I'm not a conspiracy theorist, and I'm not really trying to be a whiner either. It developed quite naturally. It doesn't mean it's good, but I don't think there's a bad guy motivating all this. It's become what I call paint by numbers medicine, such that I remember going through even school before I got into residency and watching what were supposed to be my mentors offering patients the fourth choice on the list, and I'd pull the doctor aside, carefully, diplomatically afterwards, and say, what about 1, 2, and 3 options? Like, oh yeah, insurance won't cover that, or the patient won't even comply with that. So I didn't even. I'm thinking, man, that is not the way to practice medicine. And of course, the pressures to get the patient in and out of there in 3 to 7 minutes. It's like, how can you even know what's going on with them in 3 to 7 minutes? Much less come up with, thereby a diagnosis that fits and then a treatment. So those, I guess, are my biggest frustrations with the medicine that we have today. And then sort of the other is the lack of collaboration that exists. Unfortunately, everyone's in their niche, and money, through the NIH is a big source of that because everyone's competing with one another for their grants and stuff. And so, just like we've seen with law enforcement, you brought that up. FBI is not communicating with CIA, is not communicating with local law enforcement. That's the other way around. Et cetera, et cetera. I think if we can get a little bit more of that going on, we'll do much better because we do need to specialize, but we also need to crosstalk amongst the specialties to get it right for the patient.
Yeah, I'll mention here too that just listening to you on some of the other media channels I've heard you on is it seems like my outlook on the field and some of the principles we practice in my clinic are very similar to some of the ones you have about the way you practice medicine. So it's good to hear that there's parallels there in our treatment because I the same went out and started the whole cash pay thing, and we're only out of network with some providers now because it's just there's a lot of things wrong in testing and being able to evaluate and have the time to do that and test the right way to get to the root of it. Really takes time that traditional medicine just doesn't seem to do these days, and there's a multitude of reasons for that. But no further, I wanted to get into the whole hormone replacement thing, and there's so much here we could have. You like to rant, I like to rant, so we could be here for hours if we want to, or have a couple episodes on this. But hormone replacement therapy is still kind of a new thing that people are becoming more open to, and I've experienced this in my clinic working with a lot of people of various age groups that are trying to be athletic and active and live a healthy lifestyle. But there's a huge stigma about it, whether it be getting on testosterone or estrogen or anything else that might actually help someone, because in what it seems like on the traditional medicine side is there's still just a lack of understanding of how it works, that it's actually safe. And I've seen people get mistreated. They're getting the wrong dosages of things at the wrong timings. It's messed them up more. Or men might have low testosterone. It's becoming more and more of a common thing, and they're put on antidepressants, which might just make things worse, and it's not fixing the actual problem. So, I'm very excited to have you on to talk about all this today. So, what are some of the big stigmas you see or the misunderstandings about hormone replacement therapy with testosterone and things like that?
Well, to back up maybe just a bit to what you said, and not really with semantics, but it's not understanding so much as ignorance. And what I mean by that is we have a solid understanding of the way these hormones work. We have since easily the 1950s. And whether it's some sort of stigma that was attached when the use of hormones was banned in the '76 Olympics and beyond, I don't know what happened. Your guess is as good as mine. But I'm 60, uh, and I don't look at it as a new thing. I just look at it as sort of a coming around again thing, really more so. And again, there I am kind of mincing words. I don't mean to, but that's just a difference in our age. Like twice as many years as you. So I I can't tell you what the stigma originally comes from, but the information is out there for anyone who really wants to learn about it. And like I say, it's been out for a long time. We've refined it, certainly. I mean, we used to look at total testosterone. Now we look at free testosterone more so because that's where the rubber meets the pavement for testosterone to work in the body. Um, a lot of things still need to change, per your comments. Um, but urologists are stepping up to the plate when it comes to men. I can't say the same in what I've seen for OBGYNs for women. And that's sad because people forget we share the same hormones, just different ratios, if you will, of hormones, men and women. And women need testosterone just as much. You mentioned, antidepressants. Boy, that's a big can of worms. If you look at the DSM-5, or yeah, DSM-5 now, right? The Bible of psychiatry, you'll read that depression, if it's in your genes, so to speak, if it's part of you, shows up in your late teens to early 20s. Okay, it may not be diagnosed until later. I get it, but if that's what you have, then yeah, there are many treatments that are viable and it can be very helpful. SSRIs, obviously. Before that, tricyclic antidepressants. We go on and on. Um, but what's interesting is I'd say about 95% of my patient population, if they come in on antidepressants, we get them off. Not that we're trying to necessarily, but we find that the patients don't need them, don't like them, don't want them anymore because the common expression is, well, yeah, it helped when one of my parents passed away and I felt the grief and I used them for 6 months and I felt better for having used them. But, I was still depressed afterwards and I've been on them for 10 years and they put a blanket over everything. And that's the word I hear most often, a blanket. Seriously, it's uncanny how that word is used. But it is over everything. So the lows aren't as low, but the highs aren't as high either. And you can tell there's just a mismatch between the treatment and the diagnosis because the diagnosis is wrong. Or, the treatment is wrong, excuse me, is a better one. It's not from, it's both. It's not from a parent passing away. It's from when does that normally occur in most people's lives? Somewhere around midlife, which is the same point at which the testosterone levels decrease and your hormones start to shift for the worse. And so when they get on treatment, they go, "Wow, I have all my energy and my joie de vivre back." I think that SSRI is really just kind of messing it up for me, and we wean them off. So I hope that's apropos to what you were referring to earlier. And a lot of, I have to say, a lot of psychiatrists that I've run across are catching on to this and are hip to, how this can help. The one area where it might become an issue, just sort of an off topic here, is manic depression because it could certainly leverage mania. So you might want to consider managing yeah, your dosages of whatever you're using to control mania if you're going to adopt testosterone therapy, which I would recommend. Let's just, because that's essential for a lot of things besides mood. So, change the mood altering drugs a little bit as necessary.
Cool. And so I think for a lot of people out there, they think, if you start something like this, you're going to have roid rage. You could have a heart attack, a stroke. You're going to have hair growing all over your body, out your eyeballs. Your voice is going to change. You'll lose your nuts. You're not going to be able to have kids. You'll be crying at movies. It's just used by meatheads to get bigger in the gym. Um, or, yeah, standard psychological drugs will fix these kind of mood disturbances. And the last one is, you'll go bald. So, what do we have to say about all those kind of statements and stigmas there?
Well, we can go through them one by one, but in general, well, one I can pick off that is kind of funny is roid rage. So if that were the case, then, have you ever heard of a female being accused of roid rage?
No.
Me either. And it ties into what I'm going to say because while there are some anabolic steroids, and by the way, we're talking about steroids here, guys, made from cholesterol, testosterone is, as is estrogen, etc. But anabolic steroids are synthetic molecules, right, that emphasize the anabolic properties of these steroids. But there are some anabolic steroids like halotestin, maybe trenbolone, the first of which is actually legal in this country, which blows my mind sometimes. even as a registered libertarian, because we could pick so many others that are much better without those attributes. But they can lend itself, those two, to some aggression because of the design of the steroid. But testosterone is the feel good hormone. If you do that right, you're normally going to feel better. Joie de vivre is the word I use to describe, the benefits increase in that anyway. But estrogen, which is made from testosterone, when that becomes excessive, that's what causes the moodiness and the irascibility. And that's why you see guys mainly accused of roid rage. You've seen the guy in the gym, he puts on 30 pounds. I always use it as an example in 3 months, and half of it looks like it's in his face because he's holding so much water. And he went from a regular guy to a jerk in 3 months because he's not controlling the estrogen. Now, why doesn't that happen to a female? It does to some degree. They call it PMS sometimes, right? She'll tell you, a lot of females do, not all of them, but some of them do, feel the wild swings in hormones each month. And they're designed for big swings, right? Which is why they might not suffer as much as guys who are meant to have a very small, steady amount of estrogen. And when it goes a little bit high, they get a little cranky, to say the least. Am I making sense?
Oh
So
yeah.
that's what I attribute roid rage to. When properly done, TRT or HRT, which includes more than just testosterone, it might include progesterone and estrogen, et cetera. You shouldn't have any of those side effects. You should absolutely feel better and less moody. I argue, what's one of the major causes of sort of an outburst? Stress. Testosterone is not going to give you an answer to your stress, but it sure as heck is going to give you the stamina, at least, and a better attitude to deal with it. And anyone who's been on TRT done properly will attest to that.
Yeah, for sure. Yeah, I think a lot of the misnomers about it come from probably like the bodybuilding days when these guys were running all kinds of things, and we didn't know as much back then from a general public standpoint to what we kind of know now and are getting more used to seeing and understanding about it. Um,
What's great
and
about
then,
that, the gym is a great proving ground. I mean, you either lift it or you don't, kind of, so, oh, this works or it doesn't. But the physiologic mechanisms that are attributed to the effects sometimes are just mind blowing. It's like, God, did you even like open a book in school? And that's where you can get into trouble with the so-called gym science. But otherwise, yeah, it's a pretty good proving ground. Now, just real quickly, for some of these, and I'm broad stroking the question, you mentioned all those different things. Abraham Morgentaler, associated with Harvard University, got together, chaired an international consensus in 2015, was it? It was published in 2016 through the Mayo Clinic with 9 resolutions with these international guys, all experts in their field, that I refer anybody to who wants to cut to the chase for some of these, I call it propaganda or misinformation. I don't want to call it a campaign because I don't think it's a conspiracy, but just the stuff that catches on, like, oh yeah, I never saw the movie, but I've heard it so many times. It must be very similar. Reefer madness. Oh, if you smoke dope, you're gonna eventually turn to heroin and jump off a building one day. You just listen to some of the stuff or read it and you go, what? Where did that come from? He does a very good job. He and his consortium, in boiling it down and saying, no, this is complete baloney. This is the real deal. So that's probably helpful to pretty much anybody interested in this field as a starting point, anyway.
yeah, and so you had mentioned in another podcast somewhere, you mentioned some studies too where they were talking about the risk of heart attack or stroke, I believe, and some studies that were kind of bunk studies back in the day. Do you want to
Oh,
talk about that?
yeah. You remember I think it's like 15 years ago now. It's been a while, but every 10 minutes on ESPN you'd see an ad for a class action lawsuit for if you or a relative has ever used testosterone and suffered a heart attack or stroke. That was based on such bad science that not only the publication that included it was lambasted by the profession, but Well, certainly the study people that wanted their 15 minutes of fame, I mean, they got lambasted too for even trying to suggest that it did what it did. For every study, I think there were maybe two. The one I remember most, it might have been three, but was like a VA study, and it was so poorly done. There was no assurance of compliance. They were using creams. The VA is notorious for, at least I'll say for the one out here around me, for not really caring about their patients. As a general rule, guys, and the real clincher for me that was unbelievable was all the patients in the study were in line for heart catheterization to begin with. Yeah, they had heart problems. Um, and again, there was no assurance of compliance, but the dosages they were offering these veterans were ridiculously low anyway. So basically, to my mind, and that of a lot of other physicians that wrote letters to the journal that even published this, this was proof of the opposite. They had low T, and therefore they had a greater chance of having coronary artery disease and stroke, which is what's given pretty much a given. If you look at all the other studies.
Yeah, and so what are some of the biggest risks that come with having low testosterone?
Well, here's where again I got to put on more of a scientist hat because the correlation is one thing. Just take you for example. You're a healthy guy, right? So even if you did have, say, low testosterone, the correlation between coronary artery disease, type 2 diabetes, colon cancer, prostate cancer, and osteoporosis are probably pretty slim for you as an individual because you're an otherwise healthy guy, if you even had low T. But for the average person, there is a correlation there. So I just named 5 pretty major diseases, right, that can be treated or will be furthered if you don't treat low testosterone.
And what about on the other side of that? Like people are scared to start taking something like this. Um, do the risks outweigh the reward, or vice versa? What are the risks of going on testosterone?
The risks would be, in my mind anyway, side effects, which all can be mitigated, in my experience, or resolved completely. And it really doesn't have to do directly, anyway, with testosterone replacement, if that's what we're referring to here mainly, rather than broad category of HRT. But really, the metabolites, estrogens or DHT, dihydrotestosterone. Dihydrotestosterone is the metabolite which tends, well, first of all, it's two to 5 times stronger, at least, than testosterone is in terms of its affinity and effect at the androgen receptor. So we blame dihydrotestosterone for acne. If it's in your genes, it's going to exacerbate it. And that's a big if. It's got to be in your genes. Or male pattern baldness. Now, there seems to be an association with the health of the follicle in general, so that there might be some diffuse loss of hair as you age. But, the receding hairline and the male pattern baldness, that's genetically predetermined. And male pattern baldness is definitely accelerated by dihydrotestosterone. Estrogen, we already talked about, so we can protect against those side effects with, if necessary, with drugs that block the conversion to those two metabolites, either an actual receptor blocker, they call it a SERM, a selective estrogen receptor modulator, in the case of estrogen, tamoxifen, enclomiphene, or Clomid, which is an isomer of 2 different clomiphenes, if you will. And or an AI, an aromatase inhibitor, which blocks the conversion from testosterone into excess estrogen to begin with. And then for dihydrotestosterone, we can use, the mainstay is a 5-alpha reductase inhibitor, like finasteride or dutasteride, which works directly. There are some that work indirectly, like spironolactone in a female. We can get away with using that, but that's a diuretic, and the side effect is a 5-alpha reductase. We can actually use progesterone because it will hog some of the 5-alpha reductase to make dihydroprogesterone or 5-allopregnanolone. So there's different ways to treat it, is what I'm getting at. Sorry to be long-winded, but we have a lot of options to protect against side effects. Um, Most of the side effects occur when the dosage is not properly given. In other words, a lot of what people are in fear about are when they look at someone in the gym, for example, particularly females, right? Because men can be more manly, more androgenic side effects, and it's not as much of a bother. Bigger pores, more hair on their ears than normal, that kind of stuff. It doesn't stand out so much as if a female, had those symptoms, at least in our culture, right? Um, uh, Extreme dosages, might as well get it off the table, can actually lead to clitoral enlargement, right? I should mention, though, that in my experience, as long as you stop or reduce the dose to an optimal dose, within about 6 months, all these things will reverse. But yeah, that's those are extreme dosages. Those are the and I'm not picking on anybody. I'm just saying that's like a female bodybuilder dose, right? Who's using the dose as higher than a male replacement dose. And it makes sense, right? That's where you're going to see the side effects. You're going super physiologic. But again, there's ways to control it even in that population, if you're attentive to it. You just keep, beating down the DHT and the estrogen if necessary. So no one should fear this medicine unless it's being done in the wrong hands, I have to say, right? But the medicine itself is very easy. I mean, I have a great job. I make no bones about it. I've said it just recently. There was a guy who's practicing medicine at 99. He made the Guinness Book of World Records, and I hope to beat that record. I love what I do because it comes with what we're calling risk, very little risk because it's all fixable, and most, if not everybody's very, very happy at some point. They get to that point if we have to do some fine tuning. You mentioned, and I want to come back to this for a different reason, but uh, uh, birth control, hormonal birth control, right? It's the same thing. And I tell patients, if for any reason you decide to come off of TRT, because this is a concern, well, have I wrecked myself for life? Will I, if I ruined it, my ability, that is, to produce testosterone, male or female, if I go on this? No, no more than if you went on birth control, hormonal birth control, and decided to come off it. Sometimes being able to reproduce within a month, typically 3 months at least. Now, one caveat there that I do want to come back because it made me think of something when you mentioned it. We know now that if you use those hormones prematurely, okay, like it's 16, 15 years old, granted, oftentimes making a decision to take a risk, to enable you to avoid pregnancy, which is a bigger risk. But when you're messing around at that age, you're messing with the body's development of what we call the hypothalamic pituitary adrenal axis, which needs to be fully formed. It takes approximately 26 years before we're assured that, okay, everything's fully formed. We can't mess with it now. So it's not talked about a lot, but yeah, you can be affected for life by, say, going on birth control when you're 15. And the progesterone or progestins and the estrogens that are used don't just mess with the body's estrogen and progesterone. They can also mess with a precursor to estrogen, testosterone. So it can definitely affect females to use oral hormonal birth control pills. You mentioned that earlier, and I made a note. I wanted to throw that out there. Yeah.
Yeah, I'd like to talk about that a little bit because the that's something I've been seeing like in my gym alone. Like we have a lot of 25 to 35-year-old women that don't want to get off it just because they want kids, but just because they're starting to realize, oh, like there's a lot of side effects to this stuff long term that's probably harming me more than helping me. And there's other ways to protect yourself. So people are coming off of it, but it seems like it's a hard road to go to get off of this stuff. It's not like people are just or women are just bouncing right back from getting off this, especially in what we see now is I talk to parents all the time too. We have a lot of youth athletes is kids are on this stuff at 14, 15, 16 now all the time. It's kind of like the norm to be on this because I don't really know, but from what I have heard is, there's severe menstrual cycles and things like this that are just easier not to deal with potentially, from what I know,
Well, it
and that could.
depends. Not again. I run the risk. We always do when we're broad stroking this. There might be something where it's appropriate and maybe is the best treatment. Uh, there are alternatives to treating PCOS though and regulating the period with birth control pills. One example to your point, but there might be something where okay, this is all the options that are available, and that doesn't address what a lot of times the sole reason is, which is hey, in this day and age, my 14-year-old's running around and there's a chance she might get pregnant. And that would be more of a disaster than anything I can think of. So, she's encouraged to do that. I mean, I don't want to get into the weeds of that. That's a personal decision, but medically speaking, there are trade-offs to using birth control before the age of 26. Definitely. And, getting off of birth control if you've been on it since 14 may present an issue rather than someone who's been on it at 26 and gets off it at 36. Very very different, possibly. Now there might be no problem. It happens where yeah, I'm doing fine. She may be a fertile myrtle, and it bounces back from this kind of thing very easily, just like guys who have used testosterone or anabolic steroids in their teens. Some guys are ruined, but actually most of them are not. And I think I can say the same thing about women. So I don't mean to have everybody running and ringing the bells of alarm. But it's definitely something to consider before you just go willy nilly jumping on hormones before you fully form that axis I referred to.
Yeah, and so what are some things women can explore doing that's not going on birth control to kind of regulate those menstrual cycles and everything?
It all depends upon the female and what the actual issue is. I mean, a pared down version of what they're using to regulate the cycle would be, for example, for PMS symptoms, where there's dysphoria prior to the menses. Once the menses start, there's pain, cramping, clotting, dark blood. I find that smoothing out the transition with progesterone seems to help ease those symptoms or resolve them completely. But again, we're using a hormone. We're only using it typically for 7, maximum probably 10 days out of the month. But you're doing less to the system, obviously, because you're not doing it for the full month or 21 days, depending on the birth control pills you're using, and you're only using it on one hormone. And it's really chronicity of use that causes most of the shutdown and most of the side effects, not the dose, as most people think. Your age has a big part of it, part to do with it too. But I recommend just to get off of the oral birth control if it's appropriate, using mechanical methods like an IUD is my first choice to recommend to ladies if they're a candidate, because you avoid the hormonal issue. Now I know they can use progesterone in the IUD now. Doesn't mean you have to. You can just use the old plastic or wire without a coating. But then particularly for TRT patients, because I have not seen it happen, but technically I would have to warn a female to get off or not to depend upon oral birth control if we got her on TRT, because that's messing with that whole cascade of hormones that starts with cholesterol, right? So you could conceivably throw off the birth control's ability, the hormones used to prevent conception. So yeah, that's my first go-to. Of course, guys can wear a condom, right? Uh, put it back on him. We, as a guy, yeah, we can both laugh, but I mean, there's look, IUDs aren't always the best for females and even males. Because oftentimes it can make a female have menses instead of 4 or 5 days, 10 or 12 days. That's no fun. So yeah, I mean, there's a lot of different options, but a physical barrier method is obviously avoiding any hormonal manipulation, and that's where I would go to.
Yeah. While we're on this too, I had one person write in with a question for you, just kind of asking, what do we need to know as a female powerlifter about optimizing training around the female hormone cycle? If you have anything there.
Yeah, I mean, not really that's going to help probably, but just an observation. We know that testosterone levels tend to increase coming in and during menses, which is weird. You would think because at least the way we look at it, well, testosterone increases libido. Why would Mother Nature want your libido to be increased when theoretically you can't conceive? We know a little bit more about that. We know it's a balance of hormones, and they're different for guys and for gals. Um, but we do know that testosterone levels tend to be a little bit higher during the month at the start and through menses, and for a few days afterwards. So the point being that testosterone tends to leverage recovery. You might consider that your hardest workouts are prior to and during menses, which also sounds crazy now that I'm saying it, right? Oh, great! I'm
Yeah,
having the best workouts while I'm in my menses, but I'm just saying per the per the testosterone increase, that's presumably the best way to use it. That little bump in testosterone.
I think most women, at least that I coach, would disagree with you. But
I,
is there any date?
and I'm just going based on the theory, but yeah,
Because
do what works for you for sure. This is just theoretical, of course.
yeah, because some women will come to me, especially when we have competitions coming out. It's like, great, I'm gonna have my period like the day of the meet. Like that's not where they want to be, anywhere near that. So,
Yeah, no,
uh,
but my question to them would be, well, first of all, how do you feel? How did you do? Nevertheless, is it more because of the physical issue with having to deal with bleeding, and or say the discomfort of a tampon or whatever they're using, versus and also the mental side of it versus actually what's happening. I'd love to know the answer to that question.
yeah, might be a good study someday. Um, all right, and then as far as using TRT and replacing testosterone for men here, and we're still talking about estrogen here. So we're discussing all these estrogen blockers and SERMs and things. Are there um, side effects or adverse effects from those? Because I know some of them that can be used are actually used for breast cancer patients and things like that. So something a lot of people might hear and say, "Oh, why would I want to put myself on something like that?"
Well, to answer your question, there's nothing per se with the drug that I've come across, meaning the drug itself causing the problems. It's what the drug does, and that can oversuppress estrogen. Uh, that can create an issue, just like the same symptoms of a menopausal woman who's deficient in estrogen uh, can be induced. We call it iatrogenically by using the drug. Overusing it would be the implication, or in the case of someone who's using it properly for to treat estrogen sensitive cancers, that's just a side effect of the treatment. They're trying to bury the estrogen, right? So you're going to have side effects of deficiency like palpitations, heart palpitations. I mean, night sweats, hot flashes, and that can happen in men as well as women. Women a lot more because they are more dependent upon estrogen's effects. But well, no buts. What did I answer your question?
Adverse effects from E2 blockers or estrogen blockers.
Yeah, I mean, again, it's not from the substance itself, in my experience, and there's different ways to do it. Um, the selective estrogen receptive modulators are, as the name implies, um, interesting because they will block at some places and not others, which some people claim is an advantage because let's say you obviously want to block it if you're a male at breast tissue, but not necessarily at the liver. It's the cellular level of the liver. So it might be a choice that you make for that reason. But the problem is if you're going to try and track it and optimize it with a SERM like that, you're forced to do so clinically. as opposed to with a laboratory assay where with an aromatase inhibitor, an astrazole, rexamastane, slightly different mechanisms of action, but still the same effect. You're blocking the very conversion from testosterone into excess estrogen, and then you can measure it and say, okay, great. We don't have to guess. And this is important for men, particularly because while they may not experience side effects of excess estrogen, gynecomastia, water retention, fat retention, moodiness, and irascibility because of their genes, in the long haul, these men, like women, can be affected by a certain family of estrogens called estrones, particularly two of them called 16 alpha hydroxyestrone and 4 hydroxyestrone, which are known to promote cancer in estrogen sensitive cancers, prostate cancer in guys, and breast cancer, for example, in females. So without the ability to get a beat on those that you can gain through a laboratory assay, you run the risk of a nasty surprise down the road. And just to make sure that's clear, with a SERM, you're blocking the receptor, so you're still making it. The assay for, say, in a male of estradiol sensitive might be 100, but how much of that is blocked by the tamoxifen, let's say, a SERM, we don't know. We're just guessing based upon the patient saying, yeah, I don't have any symptoms. And based upon what we think is the right dose, based upon the average, that mythical being person in the study, who didn't have any symptoms either. Whereas with the AI, the aromatase inhibitor, we have a number. We're not guessing. And we say, hey, you've got enough. We know that males need some, just like females, for heart, brain, and joint health, but we know it's not going too high because we just measured you. Does that make sense?
Absolutely, for sure. So it's good to know. Now, the big questions that a lot of people out here might want to know about is, what are some of the side effects of having the low testosterone, and what things would a male experience that might make them want to think about getting on something like testosterone or hormone replacement therapy?
Great question. So one of the mistakes, we'll start with that people make is, let's say you're a high energy guy and you're athletic and you're successful, you're kicking butt. You look around, let's say you're 45 years old and, half your friends are fat and out of shape sitting on the couch. You're going, well, I must be doing pretty good because Bob and Jim look like crap over there. And, God love them, but thank God I'm not in that position. That's a mistake because you don't want to compare yourself to others. I mean, and not to be, I don't mean this to come out the wrong way, elitist or anything like that, but everyone's got different genes and predispositions. Compare yourself to you, say 10 years ago. Okay. That's what you want to look to. Everyone's different. You got to focus on your changes, not their changes, right? Maybe they need therapy. Maybe they just need a swift kick in the butt to get off the couch and their testosterone's fine. But, I'm jumping ahead now. In terms of evaluating to even consider looking into this, it's to ask yourself, what's off with me? Do I have a decrease in energy from 10 years ago or 5 years ago, whatever it is? Do I have a decrease in libido? Do I have a decrease in just a sense of well-being? Am I bouncing out of the bed in the morning like I did when I was 20 or not? Now, you might want to temper that with, well, do I have a reason? That's where it gets dicey. I would argue that, before you spend too much time doing that, just get a laboratory assay, because it's one way to rule it out. Because we might find, no, your testosterone levels are great. But now that you think about it, you got, the 2.3 kids and a mortgage and you're working like a Jamaican with 3 jobs, so that's a pretty good reason to be tired, right? So you follow me? I mean, but those are certain signs and symptoms that pop up right away. The real, I would say, the more definitive of them is the body composition changes, where a guy, again, like you, who knows his way around the gym, knows a lot of the tricks to staying in shape, and keeping the fat off, the muscle on, et cetera, starts to have trouble despite pulling out even more and more of the tricks. Has trouble with body composition and muscle strength. And you go, okay, what's off here? because testosterone leverages all those good things you're doing, right? If you're still sleeping well, getting the right nutrition, and you're working out well, but you're not making gains, you're going backwards even, then that would be another sign to look into. Okay, what are my hormonal levels here, specifically testosterone?
Yeah. And those are some ones I kind of know about too. Is I think sleep is one for people that's like, oh, I'm just getting older. I need to get up and pee in the middle of the night, and the stress anxiety one too seems to be the other like one that a primary care might just jump to and say, oh, let's just you feel bad, let's put you on the antidepressant.
Yeah, well, we talked about that a little bit earlier. That's a false step for sure. It's funny you say the sleep though, because that's something that usually pops up upon follow up. Guys and gals don't come to my office typically thinking about hormone replacement therapy and it affecting their sleep, unless they're menopausal ladies that are suffering from night sweats, and they go, "Yeah, it's definitely affecting my sleep." But the 35, 40-year old, let's say, they're not even thinking about that, and they go, "By the way, doc, I'm sleeping so much better now." And you can make an argument, which I think is part and parcel, and it definitely could contribute that okay, they're exercising more and everything's getting better, so they're sleeping better. But a lot of it is just hey, that sense of well being comes back, and the things that they're ruminating about. Once they have the energy after 4 hours of sleep to wake up and then start thinking about. Oftentimes they wake up because they have to pee. By the way, right? Uh, will keep them up instead of like in the old days when their testosterone was high saying, I feel great. Shut up, brain. I'll handle it when I get up in the morning, like I always do. Let's go back to sleep. And in terms of the urination, not quite sure what that mechanism is. I just discussed this earlier today. In fact, there's a slight increase in aldosterone production when you're on TRT. Maybe that has something to do with holding water in better. I think generally speaking, as you get in better health, you're exercising more. All of what we call the third spaced water, the edema, gets processed by the body during the day and not necessarily at night. So the kidneys rid it before it's time to go to sleep, and you don't wake up in the middle of the night going, "Okay, gotta pee." So yeah, all those are nice little side effects though to reversing your low T into optimizing it.
And in that regard too, with the whole sleep apnea thing, that's another one that comes up, is something that can be a side effect I've heard, is people get these bigger girthier necks and everything else as that one.
Well, okay. So yes, absolutely, and that should not be ignored because any good ear, nose, and throat doctor will look at a guy with a 17-inch neck or more and go, "You got sleep apnea, dude." It's part and parcel of what comes with it. You've got with age too. Obviously, there's a lot of factors, but just having a big neck. When you sleep at night, if you're supine, those muscles will collapse through gravity, and you're being asleep now, having a little less tone, if you will, sympathetic tone, and collapse on the airway, and you'll snore. However, that is not the same thing as what most even physicians assume, because they'll see somebody who's 50, let's say, and has this in place. Let's say they have other factors, not just the 17-inch plus neck, but they're 30 pounds overweight, which also contributes to sleep apnea. They may have a large tongue that's falling back in their throat. They may have a deviated septum or turbinates that are too large, the filters in your sinuses from allergies or whatever. And before they were on testosterone, even though they had sleep apnea, their hemoglobin and hematocrit and red blood cell count might have been high or normal, maybe even on the low side, depending upon another factor I'll get to here. And the doctor said, no reason to think there's anything going on here. Oh, you're tired in the morning. Oh, yeah, you're getting old, dude. You're 50, writing it off. I mean, how many times you heard that? There's nothing wrong with you, baloney, from a doctor who doesn't know what's going on with you, rather than saying, well, there's something wrong with you. I just don't know. But anyway, then you put them on testosterone, which leverages the production of red blood cells, hemoglobin, hematocrit, and that oxygen debt they're going into during the night, during an apneic event or apneic events plural. All of a sudden, you see the high red blood cell count, hemoglobin, hematocrit. You go, oh, that's that doggone testosterone. That's what does it. No, It's sleep apnea that does it, but now you see it come to light because now you've got normal or optimized, hopefully, testosterone levels. And so the what I call the training effect, the reason why you're riding your bike 6 hours a day uphill if you want to be a good Tour de France rider, so you get more oxygen carrying capacity developed, is effectuated at night. Although it's not the same thing. So all the bright listeners out there, don't think that, oh, I don't have to do my cardio because I have sleep apnea, because you're not training your muscles and doing all the other work. You're basically just holding your breath. That's just a quick side note. But you're following me so far. It's not testosterone that's doing it. Now, supraphysiologic doses of testosterone can raise your red blood cell count and your hemoglobin and hematocrit, therefore, a little bit. Maybe, to use hemoglobin, maybe a point if you're going super physiologic. And I'm not talking about anabolic steroids, but just getting an individual's levels righted or optimized is not the cause. It's look for something else. And so that's a big one. And I'm maybe belaboring it because that's the reason why a lot of people say, well, I'm not doing that because my buddy did it. He has to go give blood every month or two. And he's on a CPAP machine now because they figured out he has sleep apnea. He didn't have it before. Well, he had it before. They just didn't figure it out 9 times out of 10. And yeah, because they haven't treated him, he's having to go and donate blood. He doesn't have to, by the way. That's a whole other concept. But in order to get the number down, yeah, that's the only way to do it. If you're a male, if you're a female who's still menstruating, well, that's a whole other deal where your sleep apnea could be hidden to some degree. You're always going to have typically always an elevated red blood cell count because your body's trying to keep up.
Mm-hmm. Interesting. And something else I've kind of heard go back and forth in this field is men or women, they feel like shit and they don't want to exercise. They don't want to be active. They have no motivation to maybe eat healthy or make, positive behavior changes. And the doctor says like, well, we're not going to put you on any of this stuff until you square all those things away first.
That's just crazy. The reason oftentimes why they're not doing any of the right things, they don't have any energy to do it. So you give them the energy back and they should be able to right the ship pretty easily. Now, I suppose if you were not unethical, you could say, now, if you don't start exercising, once I get you on TRT and turn this around in, say, 3 months, or start working that direction, honestly, in 6 weeks, you better start because you should be feeling better than I'll pull it from you. I guess you could use that as leverage if you're unethical, but that would make more sense than what you're telling me doctors would say. That, to tell you to get started first is like saying what? Jump in the car and drive down there with your 5 gallons of gas to put the gas in the car that's not there so you can't start your car. You know what I mean?
Yeah.
That doesn't make sense.
Yeah. That's totally something that I've heard of before. Now, there are certain things that we do want to think about. And like you said, like looking back to yourself 10 years ago, it probably, if this was an active guy and now all of a sudden he's not active, probably an indicator that maybe it's not him, it's what's going on inside of him with his body. That is something we should intervene on. But it seems like now too, more and more men are experiencing low testosterone and at a younger and younger age too. What are some of the reasons we can hypothesize on that?
That's a great way to put it because it still is just hypothesis. What I've seen clinically is, and there's no doubt in my mind, but I'm just an N of one. So my opinion, $5 will get you a Starbucks cup of coffee. Stress seems to be the big killer of really bodily functions in general, right? I mean, there's actually a medical term, sick thyroid, a different hormone, a lot different in that it's really a protein-based hormone, but still very volatile and certainly a great example of how stress can affect the thyroid. It will shut down under stress, and that kind of makes sense from an evolutionary standpoint, I guess. If you can't go out and hunt and gather, then we better conserve energy, right? So let's rev down, if you will. And when I see young guys coming in and gals coming in take a young lady who's 26. I remember 26 years old, and she had really low T. Now she'd already had 5 children though, and I don't care who you are and how young you are. 5 kids, that's a lot of stress. Okay. especially at an age which arguably you're not even ready for. And you're still a kid yourself. I mean, again, I sound like grandpa here, but you get my point. That's a lot of stress. Okay. So, that's typically where I see these cases where it looks to be way askew, on the left side of the curve. Why is he or she here that early? He started a startup. He dropped out of an Ivy League college. He's worth $1 billion now, but he just gave life and limb to get there, and stress buried his hormones. So that's typically it. Now, there's another theory that has to do with what we call xenoestrogens, estrogen-like components. Um, there are, gosh, I think identified at least, it's probably hundreds now of estrogen analogs in nature. I mean, you know of them, right? Tofu has diazidine and genistein in them, right? Those are, I think diazidine or genistein, I can't remember which, has like 1/500 the effects of estrogen. But these are naturally occurring things that mimic estrogen, okay? And yet we don't have anything like that with testosterone. We have things that might engender the production of testosterone, fenugreek extract supposedly and stuff like that, but not an analog. So the theory is that those, not just the natural causes, more importantly, the chemical causes, the man-made xenoestrogens are getting in the way. And, I've referenced, I don't know how they did that. I have to go back and look this up. But over the last 50 years, the testicular weight in newborn males, I guess estimated somehow with the size, I don't know how they do it, has decreased consistently over the last 50 years. So, part of it is maybe the environment. Well, I guess you could argue both is the environment, the stress from the environment. I mean, stress to me is definitely a candidate if you think about it. 300 years ago, life expectancy was what, 35? We were herding sheep, man. Stress was non existent. Occasional wolf or an attacking tribe, that was short and sweet, right? Now you wake up in the morning and, whether it's looking at your phone first thing and stressing out about your favorite team that you just got notified about, got caught for whatever. And you know what I'm saying? So stress is a big one, but I think the xenoestrogens play into it too. There's plenty of science that support that theory, but I don't think we know for sure.
And what about so you mentioned the environment. What are some environmental things out there that you see that can affect someone's hormonal levels?
Well, that's what I'm referring to, the stressful environment and these chemicals in the environment, in our water, in our foods, the additives that, I mean, what was it when you freeze water in a plastic bottle? You were getting I'm not going to remember, not the phthalates, but something else that was affecting your reception of estrogen because they were estrogen analogs. I mean, there are many of them out there. I don't know how we effectively test for their effect. It's difficult in humans because we are relatively long lived, and you're not going to find too many guys willing to say, "Well, feed me a bunch of." I just use the word phthalates. That's not what I'm looking for, but something that's potentially carcinogenic or going to be harmful to my health. I mean, so it's hard to dig back in these because they're usually retrospective studies, not prospective, for that reason, and observational. So it's kind of sticky, but the theory makes sense. Is all I can say.
Isn't yeah, like plastic bottles, like one of the things my functional medicine doctor mentioned too is like make sure you never like microwave your food in like a plastic Tupperware container or anything like that. Was one of the big ones. There are a couple others she mentioned that
For
I
some
can't
reason, and I don't
think
want
of.
to pick a fight with him at all. He's probably right, or she. But for some reason, it sticks in my head that even worse than that, not that the heating of plastics isn't poor for certain plastics, uh, or is a bad idea, but I want to say freezing your water is a big no-no because somehow the freezing releases those even more so than the heat. Anyway, I have to look that one up. Apologize.
That's okay. Um, and then are there certain new are there any other nutritional things too? So from a standpoint of maybe trying to improve your hormonal profile naturally, are there certain things we can do or should look at trying to do?
Well, if you're dealing with secondary hypogonadism, whether male or female, um, those are options for you uh, because there are ways to effectuate more production. We know that. I mean, you can do all kinds of things. We use for example, GH, growth hormone secretagogues effectively. Um, Interestingly, though, since we're on the topic of estrogens and some of the estrogen analogs, it's the opposite from what we were taught when it comes to females and males, actually. Meaning, if someone is, say, reaching perimenopause or menopausal, where let's just be specific, having symptoms of estrogen deficiency, to use products like tofu that contain genistein and diazidine doesn't make a whole lot of sense. You would have to eat so much of that tofu to ameliorate symptoms at some point that it actually gets in the way. And I would argue that during those periods where you're not completely menopausal, you are absolutely getting in the way. Without getting into the sneakers they're wearing and the affinity, how quickly they get to the receptor. Okay, if you've got something with 1/500th the effect getting to the receptor before something that has the 1-to-1 ratio you're looking for, estrogen, that's going to mess with you. It's actually worse for you if you're in that period to use something that will bind to the receptor but has 1/500th the effect. Duh, right? And the opposite is true for males. If you have a problem with excess estrogen, right, which is what we're concerned with typically, eat all the tofu you want. You're not going to be able to eat enough to actually effectuate estrogenic symptoms, okay? But you will be using something with, for example, 1/500th the effect in place of the estrogen you're producing. So we've had it backwards for all this time, in my opinion, because of the reasons I state. Those are the classics, right? Estrogen type foods. We know
So,
that
so
alcohol and marijuana tend to activate the aromatase enzyme in the liver. Okay, so that'll lead to more conversion into estrogen. Is that helpful?
yeah, just to get this straight, so you're saying men should eat tofu because, or like, would that even be like a soy type product too? That's supposed to be estrogenic, where it's only a
Well,
one
if,
hundredth.
I don't want to make a general statement that guys should eat tofu and women shouldn't. I'm just saying that if the purpose is to, or if the thought is that you've got something with an estrogen analog in it, for a female to eat that substance thinking it's going to help the situation is backwards, and ditto for a male thinking that by eating something that has this estrogen analog in it, it's going to further symptoms. The opposite is true because of the way it works. You've got something that's going to attach to the receptor that has a lesser effect in terms of estrogen um, um, effects than estrogen
Okay,
itself, right?
interesting. So I have a very high level power lifter, athlete that she's a vegan and she is jacked out of her mind and she's super strong and she's, genetically she's kind of a freak, but I'm pretty sure she eats a hell of a lot of tofu. Could this be something that, like, for a female in a performance strength sport, could be helping her?
Absolutely, but I would argue it's for the protein. As
Okay.
a vegan, I was a vegan for a while. I loved it. I just couldn't keep up. I had to eat so much. But I have a shirt that says "vegan," being asked 12 times a day how you get your protein. Right? It's a joke. It's actually quite easy. But if a lot of people, I shouldn't say a lot, but a significant percentage of the population have issues digesting soy products, so it's worth mentioning that some can't. But if she can get away with it, what an easy and great source, because tofu, I mean, I've made chocolate pudding out of it. I mean, basically whatever you infuse it with is what it tastes like. If you don't mind the texture, and they can have different textures. From very what is it, malleable to very hard chunks of tofu that can resemble, want it to resemble animal products, if that's what you're looking for. But no, I mean, I would think it's from that. I don't. In other words, if you're thinking that it's maybe because of the estrogenic effects of soy, I don't think that has anything to do with it.
Interesting. Cool. Good to know. I'll let her know. Um, so just a few more things I wanted to touch on here too. So it sounds like we know a lot about hormones and in supplementing them. Uh, One of the big things, I don't know how popular it is right now, but SARMs, selective androgenic, I forget what it is, but SARMs were the big thing in the gyms a couple years ago that kids were taking because it's like, oh, well, it's not a steroid, um, even though we don't really know much about its safety from what I that I've seen or read about. So, do you want to touch on those at all? Of like, is this something someone should even bother with when we have all this other information and studies on um, actual steroid hormones that do work and are relatively safe?
It's kind of a loaded question because I would say yes, simply because I think we should further our knowledge with SARMs, selective androgen receptor modulators, because who knows what we'll come up with. Um, in the meantime, though, yeah, I would argue, I think, as you're stating or suggesting, one position anyway is, why bother? Because in with what we've gotten so far in terms of the SARMs that are popular, like Ostarine and what is it, Luganda, LGD, something or other. I mean, there's some that have been out for a while that have been not necessarily tested in the classic sense, but utilized in the gym. Um, I had a partner in the practice at one point that had a connection with one of the manufacturers for Ostarine, and they sponsored a study, and we used volunteers in our practice, the athletes specifically, mainly bicyclists, but we had a lot of different athletes. And we had to give them the thumbs down. They were not happy about that. But the reason why we gave them the thumbs down, we were using 25 milligrams, I think it was, of Ostarine, is because, yes, it binds to the androgen receptor and has many of the effects. And each of these, SARMs uh, can have a multitude of effects. I mean, what I love about them is that, you can build these different structures, and just like the anabolic steroids, depending upon the structure, they'll go into the cell and affect, depending upon where it binds and how, and the way it reconfigures the receptor, et cetera, different effects can be had. So the trick will be, as I suggested, my first response, let's do some more research and let's fine tune these and make the best out of them. You're still going to have a problem, like all anabolic steroids, of negative, what we call negatively affecting the lipids. And I'm rolling my eyes because unless you have an issue, meaning specifically extant coronary artery disease, plaque in the arteries, I don't really care too much, particularly in the short term, maybe more so in the long term, if we lower your HDL and raise your LDL. That's a whole other conversation about cholesterol and the baloney that's spewed about, cholesterol being bad for you. Okay, it's all very circumstantial if it's bad for you. After all, cholesterol is what makes these hormones we're talking about, some of them we're talking about. Without it, we'd be screwed. But that's a whole other topic. And I'm happy to talk about it one time, but this would definitely be a big aside. So with
Make a
SARMs,
second episode.
yeah, deal. SARMs, though, I think have a lot of potential, but if you compare them to what we have available, I don't think they compare at all. The negative effects on lipids and the effects, now maybe 25 milligrams of Ostarine is not enough, but one presumption, and it's just a presumption, is if you increase the dose, you might get marginal increased effects that you're looking for, but even more negative side effects on lipids. So, I mean, personally, and this, I don't even know why I'm going to waste your time, but I started because I'm saying personally, I think a lot of the glitter surrounding SARMs has to do with the fact that it's a way to do it yourself. And because of the way anabolics and testosterone has been treated to date anyway, and because of the accusations of abuse, which arguably it is when you're using crazy amounts, people don't want to be lectured. They want to be free to do whatever they want. And the fact that they can get these on the open market, none of them are FDA approved. Um, uh, but they can find them and they're relatively cheap, um, and they can get some results out of them. I think that's what gave them their luster in the beginning. But I don't see a lot of people saying, "Wow, man, that particular SARM is the best thing I've ever done in my life." And I don't hear about, and a lot of my practice, I hear about these things. I go and train over at Gold's in Venice and see these guys and talk to them in the gym. they're not talking about the latest SARM, getting them on stage or, helping them perform, lifts better. If anything, they're talking about the standard things you always need, proper nutrition, rest, and the right exercises and whatnot. But they're using anabolic steroids. They're still the best option out there for those things that people are using them for.
Mm-hmm. Speaking on that regard too, what? Because I've had this a couple times. Is guys will come to me because I'm in the medical field and I'm the closest thing they have to uh, a real doctor. I tell people that, yeah, I'm a fake doctor. I prescribe exercise, not medication. But
Best thing you can
I've
prescribe.
had, yeah, for sure. But people will ask me like, "Hey, I'm taking all these things and I'm scared to go to my doctor and like have blood labs done because I don't want them to know I'm on all these things or running this gear and this and that." And like, what should I do? I'm like, you should probably get some labs done regardless because it's your own health and you don't know what you're doing to your body if you're not testing anything. Um, so if someone's in that situation where they've got themselves running all these crazy, stacks or whatever, um, what should someone do? Who should they go to?
Oh, you're also loaded the question of crazy stacks, but given what you're saying, I understand. Yeah, first of all, absolutely find a physician and go through it with somebody who has, well, their head screwed on straight. Is the best way I can put it. I don't mean to be provocative, but look, there's good and bad in everything, and there's different doctors that have different expertises. But when I say head screwed on straight, you definitely don't. And I get it. Who wants to get a lecture from somebody who has just an opinion that's not based upon science at all? And it's still out there. I mean, I'm sure. I mean, when I was growing up, I heard about it because I'd asked doctors before I ever took anything. I asked. I said, "What do you think about this?" I think I was 13. I said, "Well, what do you know about this?" And I got the lecture like I was some, ne'er do well. How dare I even ask a question like that? What are you, stupid? And nobody wants to hear that. I get it. But in this day and age, I think you should be able to go to really any physician and get, and I know this isn't what's going to happen, but, hey, that's not my specialty. Let me refer you to somebody who knows more about it than I do. But you shouldn't get a lecture. I get it. But the onus is on this individual or these individuals you're talking about. You gotta be your own best advocate. And if this doctor doesn't work, find another one. Find one that you can talk to and feel comfortable talking to, and get it right. Because yeah, there are some crazy things out there. I'm not going to tell you that I don't green light a lot of things that come through here. I mean, I'm usually fixing a bad haircut and then explaining why too. I mean, I'm not going to give them a hard time, but I'm going to shoot straight with you. The problem I see out there, and this might be too much of a tangent, but a lot of the people that are making the recommendations for these, we'll call them anabolic cycles that people are doing, are the same people that are selling them to these individuals. There is a conflict of interest, guys. Okay. There's a proper way to do this and an improper way. And what feeds upon that too is because a lot of these anabolic steroids are made underground, right? They call it. They're not potent. You might have something that's labeled, Primobolan 100, which, by the way, is not legal in this country. Okay, it's not. It shouldn't even be around in the sense that, I mean, if it's here, it's illegal to begin with. It's contraband. But let's say let's use something that isn't illegal. So Anavar, what people know as Anavar, oxandrolone. It says it's 100 milligrams. If you're taking 100 milligrams of oxandrolone, you're probably going to start breaking out in a sweat and feeling very anxious. So the fact that you don't and you're taking that is a sure sign that it's probably not nearly as potent. But follow me here because I'm trying to get to a point. My point is that leads to people believing that you need twice as much because they say, well, I took 2 a day and I felt something, but it was no big deal. Yeah, because it was probably only, let's just say 10 milligrams in each one of those things. So it just leads to this. And I'm not trying to give anybody a lecture. Like I always say, I'm a registered libertarian. You do whatever you want. I got to stick to the law because I want to and because I got a license I need to protect and I want to do it the right way. So I'm not giving a lecture. I'm trying to give good advice, though, and make it understandable so you realize, okay, wait a minute. Yeah, that makes sense. That's why my buddy is telling me he was doing, 200 milligrams a day of Anavar, or that's what I read on the blogs. And yet my doctor, for good reason, let's say, is prescribing me, only 20 milligrams a day to recover from the car accident I was in or whatever. And they're torn between listening to their buddy who's telling them they're crazy and the doctor's quack, and the reality of it. Hopefully that makes sense. You know.
Yeah, for sure. And yeah, I remember this patient vividly, being scared that like his health insurance company would find out. Is that anything anyone should ever worry about?
Yeah, actually, I mean that does make sense because while I don't really deal with insurance except as a patient, who knows what they have in their contract that would exclude you from being treated if they found out you did this, that, and the other, which goes against the contract. I don't really know about that. I mean, yeah, like, well, I would think that'd be more of a life insurance question, but now you're getting outside of my bailiwick of knowledge. I don't know. I shouldn't even weigh in on that. But I can understand, yeah, being worried about what a provider would do for you because that's finances, and they can, I think, make up pretty much any rule they want within certain legal, constraints. I'm sure.
Yeah. Um, all right, interesting. And one thing I heard you mention last time on Mind Pump, which was just like this past week that came out. You're talking about peptides too, so that's kind of in the same realm of there are these new things. There's a lot of promise to them, but there's some things we don't know about them. I think some of them are banned, but some of them seem to have some real good promise. I even heard you mentioned one, and I was like, my ears perked up because the gut health issues I've had, and I think it was BP 157, which is supposed to be a pretty good recovery agent and things too, because a lot of people come to me asking about that because they have tendinopathy and tendonitis and some type of joint pain, and they think that maybe this is the magic bullet for them to fix that. So, what do we have on peptides?
Well, I was going great with you there until we said magic bullet because that's rarely the case in medicine. Normally, I love the expression that as a doctor and medicine itself, we're really uh, getting something out of the way so that the body can heal itself, right? And that's not a magic bullet. I mean, surgeries are arguably something close to a magic bullet where we might reattach.
No,
What's
no,
that?
no. Sometimes,
No, I'm not using
sometimes.
one specific example. Like we reattach a
Yeah,
tendon, that's kind of a magic bullet. But even then, we have to wait for the body to completely heal itself and get back to normal, that kind of stuff. So, the idea of a magic bullet is kind of a weird one. Closest thing to that maybe would be gene editing. And some immunotherapies which are linked. But anyway, I'm sorry, I don't mean to digress too much. But I understand your point. I'm really excited about peptides because I use the example. They're like Tinker Toys, right? You're too young for those, but you can piece them together in any like an infinite manner of ways, and therefore affect the way they affect the cell to effectuate certain changes within the cell and without the cell, and communications between cells, et cetera, et cetera. So that's exciting to me. I think well ahead of like SARMs, for example, because with these peptides, we can do so much more easily, and we have a bigger advance in terms of knowledge because they've been around for a long time. We've been manufacturing synthetic insulin for a long time because that's a peptide that's absolutely necessary. Um, and we're improving upon their short acting nature so they can become even more potent. And there's a lot of room for gains there. And so far, so good in terms of, I mean, a simple one that's very easy to embrace because it's been FDA approved. Even though I always get the brand name wrong, it's like by Vilas or by that. It's a libido enhancing peptide FDA approved for females, used off label for men because it works just as well or better and effectuates better erectile function. But that's a peptide. Most people know it as PT141. Interesting story as to how it was developed. The guy who was working on it um, overdosed himself and had like an 11 or maybe it was an 8-hour erection.
Ugh.
Unfortunately, he got sick because it made him nauseous. It used so much, but that's how he found out. Oh my God, it has this effect on erectile function. Very close to it's one of the melanocortitropins. They called it
Oh,
melanotan. for helping and that was, I think it is actually a patented or trademarked formulation originally in Australia, maybe, because they were trying to use that peptide to help people get darker skin to protect them from the sun. A lot of Australians are obviously immigrants from England and fair skinned people. So, I mean, to me, those are like, that's using your noodle. That's so cool. And it's just a peptide. Very easy with what are the side effects? If you overdose them, aspirin can be a problem. Aspirin can kill you. Tums can kill you. You can eat too many Tums at one sitting and kill yourself. But relatively speaking, these provide little side effect. One of the benefits, honestly, of their being so short acting, they're a little safer that way. Yeah, like BPC 157, we've got mainly animal studies right now, but I can tell you anecdotally, it's a home run for a lot of people. One of the problems is it's invariably an issue. We don't have the studies just yet, and you've got anecdotal information that's conflicting. And a lot of times it's because that gym proving ground says absolutely yes. We're using it, we're actually injecting it into the damaged tendon, it's worked, it's doing great, versus somebody who's using it for, I don't know, a torn muscle. That's not what it's for. They've misdiagnosed it, or they just haven't connected the dots, and they go, oh, it doesn't work at all. So, like usual, until we get the gold standard, a randomized placebo-controlled study, we're not going to see as much of it bandied about. But I can tell you, from being in the gym and in practice, that a lot of these things work really, really well. One of my favorites, the GH secretagogues, they're on the radar all the time, right? Everyone wants to improve their growth hormone levels in the gym because they know or they believe it's going to make them more lean, and they think it's going to help them with more muscle mass, although I'd argue it's more just hydrating the extant muscle mass they have. But those clearly work. You can see someone take, well, not a peptide in this case, but one of my favorites, ibutamoren, which on the boards is listed as MK677, right? That one, I've seen things that aren't supposed to be able to happen because of the negative feedback loop that we get, right? Where if enough growth hormone is produced, or really more to the point, IGF-1, the body says, okay, I'm not producing any more growth hormone, that's it. And yet I've seen, I think the record is a 464 nanograms per milliliter of IGF-1 with ibutamoren. That's not supposed to be possible, and yet it happens. So we know they work. The side effect profile seems to be very, very low. Now, I say that, and just using growth hormone as an example, again, if someone has cancer, even just skin cancer, and they're stupid enough to, or I don't want to say stupid or ignorant enough or whatever, to use growth hormone, well, you're furthering the chances of the cancer growing. That's going to give it a bad name. So all these things have to be properly used as usual. But no, there's a lot of promise with peptides. A lot of promise.
Good to know. And that's about it I had for you. I think one more thing, and this is something I learned in school, and I think you'd mentioned it before, but you didn't get too much into it. Back to women was hormone replacement therapy, or maybe estrogens, maybe something else for women. Um, I heard, I think this is in PT school actually, that one of the side effects is osteopenia, osteoporosis, and breaking bones, that has made a lot of women fearful of taking that route and just dealing with postmenopausal syndrome and things like that. Is this completely false? Is this something women should be worried about? Is this poor study design like some of the testosterone studies?
Well, yes, it's completely false. It's actually the other way around. Estrogen is known to help prevent or reverse osteoporosis when combined with weight-bearing exercise and a proper diet, rest, etc. Um, but I'll tell you where I think you're going with this, and you can correct me. But a lot of the fear around estrogen replacement comes from the Women's Health Initiative, which really was a great study. It was very, very well powered. But the estrogen that was used was Premarin. And Premarin stands for pregnant mare urine. And roughly 50%, I think it might be 45% of that is equilin, The other roughly half is a human hormone, estradiol. But equilin is 1,000 times more potent on, say, the human uterus than estradiol is. So you can see how an 8 in 10,000 increased risk of estrogen-sensitive cancers could arise from using that formulation, right? As the study showed. So that sent a lot of, I would consider, false shockwaves through the system regarding estrogen use. Also, I believe it's still also an 8 in 10,000 increased risk of stroke. Again, we're using horse estrogens, guys and girls. So you can understand how there might be a problem. In the world of bioidentical hormone replacement therapy using bioidentical estrogens like estriol, typically 80% estriol and 20% estradiol, anecdotally now, we haven't done a women's health initiative type study yet, never seen any issues with this. It's comparing apples and oranges. Okay. And Jonathan Wright was one of the first doctors to point this out. I have to give him credit where it's due. So it's led to a lot of false concerns over the use of estrogen. That said, whenever I recommend estrogen to a female patient, I will say, look, in the interest of being overcautious, if you will, let's look at this as a reality, nevertheless, even though it's flawed. To reduce the increased risk of estrogen-sensitive cancers, let's use the DIM, to which we were talking about earlier, diethylmethane, or eat lots of cruciferous vegetables, to keep the bad estrogens from converting into, the good estrogens from converting the bad, but more so to convert the bad into the good, or equally so, I guess is a better way to put it. And as far as stroke risk, good old-fashioned fish oil works great to make platelets less sticky and reduce the coagulation factor, right? That's associated with stroke, or this type of stroke that was noted in the study. Both of those are going to provide health benefits anyway. So where's the risk? Where's the loss, right? And you're protecting something that arguably doesn't exist, but you're covering your bases nevertheless. That's my take on estrogen. How's that in a nutshell for
That's
women?
very good. Yeah, that's very good.
And one more thing I want to add too. It's a common misconception that estrogen for females is the only way to attack osteoporosis. It's mind-boggling to me. Testosterone will do it too, along with weight-bearing exercise and eating right. And interestingly too, because when you're on TRT, not necessarily with estrogen replacement therapy, you're going to hoard calcium more so. And so you don't even need calcium supplements, which I wouldn't recommend anyway. Just a vitamin D, a vitamin D3 supplement along with your TRT. The extra calcium would just stop you up, and who needs that? Well, I guess if you did have an issue with loose stool, but anyway, my point is, it works as or more effectively than estrogen therapy.
Awesome. Last thing I wanted to go through, and this is something I think is the biggest part of being someone that is a patient in the trying to navigate this world, and someone finds out, they've tested low for, or their hormone profile is off, and they think they might want to consider this. And I think it's kind of all over the place right now. Will PCPs prescribe hormone therapy? Should they? Should people go to their PCP for this stuff? Should they see their urologist, an endocrinologist, someone in your type of setting like regenerative medicine? What's the best place for someone to go to start doing this? Because my big thing is making sure people end up at the right place and get the right type of treatment, and not go to someone that says, yeah, I can prescribe you this, and completely mess you up.
That's a great question to which I don't have an answer, because I think it just depends upon how things evolve. I've mentioned that the urologists look like they're taking over the space for men, and that seems to me appropriate. Why not have them carry the ball? Because guys will come to a urologist with very many related complaints, meaning related to testosterone. So that makes sense to me. I would hope, just because it also makes sense, that the gynecologists, OBGYNs would pick up the ball for females, because that makes sense too. They're going to come with complaints. I mean, Yeah, that are related, even though people think of it as, for the parts. It's also, I mean, a lot of times, certainly when I was in school, and I think still to this day, the OBGYNs were the gatekeepers, the primary care physicians for women anyway. Now, you asked a question about primary care physicians. Why not? I mean, you know, you don't want to be, what is it? As a doctor, you don't want to, what do they say, be a jack of all trades, master of none. But arguably, a primary care physician is supposed to be that person and then be able to refer out to the experts. It all depends on the primary care physician and what he or she wants to focus on. So that's going to be more of a roll of the dice, if you will. But hopefully, or the hope is that this is becoming more and more available to physicians and patients who are then asking their primary care physicians about it. So it's going to be one of those things that becomes very, very common so that a primary care physician will either do it himself or herself or refer it out. Unfortunately, and here's the one, and I don't mean to be the, don't shoot the messenger, but man, you would think this is hormones. You would think endocrinologists would be the ones, right? But I think they have such a bad record now with patients because that's who you go to first. And not to make excuses, but if you think about the way they're trained, endocrinologists, we're all trained in a hospital setting, right? And then we're sent out to local family practice settings or whatever to learn our trade. Well, you don't have guys and girls being wheeled into the emergency room of a hospital with low testosterone. You do, however, have them wheeled in with Graves' thyroid storm, Graves' disease, a thyroid storm, and diabetic ketoacidosis. So endocrinologists have learned, this is my opinion, to focus on thyroid and pancreas, diabetes and thyroid issues. And when it comes to testosterone, I remember really testosterone and estrogen was maybe 10 minutes of my training in school.
Wow.
I'm talking about just in the books. I brought it up one time. One of my favorite doctors and professors, we'll call him, in med school, Dr. Joseph Wansky. Love the man. Double boarded in endocrinology and internal medicine. And I can remember he was a 73-year-old African American male with cachexia, secondary to terminal cancer, and we were given him Megace, which is an estrogen substance, okay, to help with appetite and to hold weight on him. And I remember thinking, God, I'm going to show Dr. Wansky I got some information that he might not have, or I have something he knows, and I figured it out. I said, how about we give this guy some testosterone? And you'd have thought that I shot the pooch, man. I mean, he looked at me like I was out of my mind. And I don't mean this with any disrespect. He really is one of my favorite doctors of all time. But to me, it just emphasized the point I'm trying to make, that that's not part of the standard doctor's training. And again, to his defense, not that he needs any defense from me, he's in a hospital setting. So he's seeing the same thing day in and day out. Whereas, to my point earlier, a primary care physician, especially nowadays, in our time right now, is going to start seeing more and more of that. And we'll start to, therefore have to do a little more research beyond the standard training we're given in a hospital setting or, standard medical school.
For sure. All right, so I think that about covers everything I had on my agenda today. Anything else you'd like to add?
No, just thanks for having me, man. As you can tell, I enjoy talking about this kind of stuff. So anytime.
Yeah, it's been awesome to talk to you. It's been awesome to have you on. And, we spoke before this, and I feel like the little kid that got his first big star on the show. So it's been
Nice.
good to have you on here. And, very gracious of you to be on this when you could be doing something on ESPN, I guess. So I feel like I've almost made it. So, Dr. Rand, where can our listeners find you?
I get asked that. So I think the best way is just to come to our website, PSRmed, Papa Sierra Romeo Med.com. And, we got all our phone numbers and stuff on there, and hopefully some information on there that, readers will find useful too.
Yeah. And we'll put that in the show notes and everything too. And you can just Google Dr. Rand McClain and it'll come right up with his website and everything as well. One of his two websites will pop up. So it should. So again, thank you. And if you guys have any questions for Dr. Rand as well, and you can't find him, or you have questions you want to put through me, feel free to message me. And I look forward to getting this episode out there and hopefully having you on again. And maybe we can talk about some more of these peptides and estrogens and everything else. So
And there'll be a lot
again,
more to talk about.
thanks.
So I look forward to it, Brett. Please, anytime.
Yeah. So thanks for coming on. And for everyone else, stick around next time. We have Kevin Duffy coming on, who's a TPI golf pro. We're going to be talking about some training and injury prevention there. So stay tuned for that next time. Thanks.